Good evening, everyone. Thank you so much for being with us tonight for part one of a very special three-part seminar series that we are hosting on the history of the development of the FOH phenotype of bipolar disorder. Now, tonight you may hear us, myself and my special guest, Dr. Demitri Papolos, talking about this disorder in a couple of different names. And so those names might be fear of harm, they might be FOH, it might be TSDD, it might be thermoregulatory sleep dysregulation disorder. All of those things are really the same thing, because fear of harm, or FOH for short, is what this disorder was initially referred to as when it was first identified 20 years ago. As a result of the decades of research that have gone on since then, the name has evolved, and that name has evolved to, at this point in time, being referred to as thermoregulatory sleep dysregulation disorder, or TSDD. But most folks know it by FOH, and so we will be calling it by that primarily this evening. For those of you who are new to CMHRC and or JBRF, my name is Elizabeth Errico. I'm the Executive Director of the Children's Mental Health Resource Center, and our mission is to provide guidance and resources for the early identification and management of mood disorders, bipolar disorder, and yes, fear of harm. With me tonight is Dr. Demitri Papolos. He is the Research Director at the Juvenile Bipolar Research Foundation. He's the author of the book, The Bipolar Child, and he is also a child and adolescent psychiatrist and responsible for the team that first identified fear of harm and has led the research into this groundbreaking new disorder. Tonight, we are going to be covering these topics: the patient's search for treatment, finding the phenotype, the fear of harm index, temperature dysregulation, circadian rhythms and sleep disruptions, as well as the FOH phenotype itself. Now, to set the stage for you to understand why it is so important for providers and practitioners to understand this new disorder and to be able to treat it, we wanted to share with you what the experience is like for families as they seek treatment for children who have this disorder. When they seek treatment, these are some of the things that parents have said to us. This condition is like a wild animal living in your house, terrorizing your child. It is just a constant presence and a constant stressor, and it makes it difficult to feel like you or your child can have a normal life. Another parent said, I knew my daughter needed help, and I knew what help she needed, and I literally was not getting it anywhere. The real difficulty was finding people that understood what was going on with her, because every single one of our practitioners has said that she was the most complex case they had ever seen. Another parent said, we were always stabbing in the dark, trying to find some expert who could tell us something useful. There were a lot of failed attempts and blind alleys until we found the one thing that did, and then everything changed. So, Dr. Papolos, can you help our audience to understand why there is so much confusion about this diagnosis and why children are being misdiagnosed so frequently?
Sure. Well, I will do my best to do that. I think one of the larger problems is that it shares so many of the DSM conditions that we know of. I'm sorry. I think you really were asking me a different question. Where we began, right? How we started this search for treatment. So let me go back historically to really what it goes back to as far back as 2002, when we began to work to identify homogeneous phenotypes or subtypes of pediatric bipolar disorder. At the time, there was general agreement and a growing shared consensus within the clinical and research communities that the combination of what are termed dimensional approaches would more closely identified with psychological studies of personality development, such as reward dependence, approach avoidance, or for that matter, fear of harm, that looking at these particular traits would be much more likely to yield results as diagnostic measures for genetic and imaging studies than the broad categorical consensus-driven DSM categories. And indeed, at that time, there were several reports that were published when we began our studies that had used both the standard diagnostic models and the comorbid symptoms of specifically psychosis, suicidal behavior, and panic disorder to identify more specific subtypes for a genome-wide linkage scan that we were intending. In this study, over half the regions implicated by the strongest linkage signals were identified using these combined, very distinctive subtypes that were more like trait markers than specifically categorical diagnoses. The availability at that time of an internet-based data acquisition system that had been developed to capture and archive clinical profiles on thousands of children and adolescents, coupled with the requirements of a genetic linkage study, enabled us to explore the use of this dimensional approach to diagnosis. And this encompassed heritable behavioral trait markers and refined clinical correlates to establish more distinct behavioral subtypes. This internet acquisition system, which was only available for us anyway in the early 2000s, it over time, it permitted us to gather several thousands of clinical profiles from a broad community sample. We had 5,000 and over 5,300 clinical profiles when we started to look for more specific phenotypes or subtypes.
Now, Dr. Papolos, a diagnostic assessment tool was developed out of this research, wasn't it?
Mm-hmm. Yes, it was.
The Child Bipolar Questionnaire, which is referred to as the CBQ and can be found on the JBRF website, by the way.
Yeah, and it was the initial screening tool that we developed at the time. People may or may not remember, although it's still quite with us these days. There was a lot of beliefs that childhood onset bipolar disorder didn't exist, even though there had been a really significant amount of research literature and that had gone in and that had really described a number of features of what it looked like in children. So we developed this questionnaire, which has proved very useful in the assessment of a range and severity of the symptoms in this very large population that we gathered information on, and who were at high risk for the disorder based on an enriched family history or actually a community diagnosis of bipolar disorder. So the CBQ is a 65-item self-administered parent report measure, which we used essentially to establish initial eligibility for the clinical and genetic studies on pediatric bipolar disorder that we would go on to do. And this screening tool was constructed based on a model that had been proposed and developed by Depew, who developed and validated what's well known in the field as the general behavioral inventory, and this they derived a dimensional approach for defining bipolar disorder in adults. And this is essentially what we did for bipolar disorder in youth. Now, what we found when we did the reliability and validation study is that the retest data really showed excellent reliability for the CBQ and for what we call the core index subscale, which eventually turned out to be essentially the FOH in terms of the symptoms that were drawn from the CBQ. These were the defining symptoms, it turns out. So the screening algorithms really performed well. There was a specificity of 97% and a sensitivity of 76%. And we were looking at individuals who had been classified with what was, and I think still is, the diagnostic, the Kitty SADS diagnostic interview that looked at bipolar disorder versus no bipolar disorder.
Were there other assessment tools that were used in the course of this research? And if so, what were they?
Yeah, in addition to the CBQ, we gathered parent reports from this same population with two other standardized and well-validated Likert scale, base scales and severity scales. One was the Y-BOX, the Yale Brown Obsessive Compulsive Scale, and the other was the Overt Aggression Scale. These three together were the three principal instruments that we used to obtain diagnostic information for our studies through the JBRF internet-based acquisition program.
Can you talk us through the Y-BOX and what was observed through this measure?
Yeah, well, we had observed in an earlier clinical sample that in these children, there was a really consistent association between the fears that children would be harmed, fear of intruders, fear they would die, and also they were afraid of their own aggressive and also self-directed aggressive behaviors. This clinical observation led to the first query of the larger data set that we had gathered. And at that time, it was encompassed about 2,000 clinical profiles. So as a first hypothesis, we chose to examine whether recurrent intense fears about harm to self or others would be positively related to aggressive acts directed towards self and others. So to form a fear of harm index, we used a combination of high item scores on both the Y-BOX aggressive obsession subscale, which I think comprises, 6 or 7 items, and a subscale from the OAS of the most severe aggressive behaviors directed at others and self. So that was those were the items that were taken from these two instruments as we went forward.
So it seems from the OAS that these are very severe forms of persistent aggression that these kids were experiencing.
Yeah, it was quite shocking. I mean, rarely do clinicians ask these questions about, either parents or look for them. But these kids really had, both children and adolescents had both persistent and morbid fear of harm anxieties, as well as really severe or overt aggressive and sometimes violent behaviors. So this fear of harm trait in individuals, in retrospect, as we look back at what we now know, was also strongly associated with parent-reported severe injury to self and others in the child. And the high fear of harm subjects were reported to make serious suicide threats much more frequently than low fear of harm subjects.
So when you examined this data, what did it show was a likely indication of the number of kids who had this specific phenotype?
Yeah, well, as you can see in this slide, when we examine the distribution of this FOH index in a sample of 1,729 cases, with or at risk for childhood onset bipolar disorder, one of the most striking findings was that a full third of the group had no FOH symptoms at all. And when we think about how genetic, behavioral genetic or any genetic trait sort of segregate in populations, that's something that stands out. That there's a separate group that actually has none of the symptoms. We divided the total group into three groups. The group with no FOH symptoms, which had no positively endorsed FOH index items. And then subjects with values of 1 to 7 positively endorsed items were designated low FOH. And the high FOH group, which included subjects with values of 7 or more of these items. So, although there were no significant differences found between the rates of females and males on the fear of harm index, nor a significant age difference among the groups, there were pronounced differences on severity and course of illness.
These look like some pretty severe measurements in terms of what variables you were measuring.
Yeah, we really chose to look at some pretty basic, fundamental things that would characterize severity in any psychiatric illness. And ever hospitalized, held back a grade, suspended from school. And as you can see on the slide, these findings underscored that we were dealing with a very severe condition that resulted in high rates of psychiatric hospitalization at an early age, as well as significant disruptions in school adjustment. As we followed these cases longitudinally, we've determined that specific associated behaviors such as school phobia, oppositional defiance towards authority figures, and misperception of neutral events, that's tone of voice, facial expressions, as threatening, were cardinal features of the condition. While the course of illness variables, such as age of onset of the first symptoms, age at initial psychiatric evaluation or diagnosis, and age at first hospitalization, did not vary significantly among the no, low, or high fear of harm subgroups. The number of psychiatric hospitalizations that were reported for the high FOH group was significantly higher than their counterparts. So these children are often admitted to psychiatric hospital. So as we look back, the primary inclusion criteria for this group of 967 children and adolescents were very high scores on the CBQ total score, and also the core index subscale, which turns out to represent significantly associated with a fear of harm diagnosis, and also that a community diagnosis of juvenile bipolar disorder. That is to say, someone in the community diagnosed the child at one point with having some form of bipolar disorder, and also an enriched family history for bipolar disorder. So, we really segregated out as best we could with what we knew at the time, a group of individuals who would be described by most child bipolar researchers, I would say, as having a bipolar disorder. And then we did this further analysis looking for subtypes, and this is what emerged. So it's important to note that the comparisons were being made between very symptomatic subgroups, these FOH subgroups, that were distinguished primarily by the presence of the FOH trait.
So, Dr. Papolos, can you help our audience understand how this data led to the identification of the symptoms that are characteristic of the phenotype?
Yeah, sure. And that was the next step in what we wanted to find out. I mean, we had what we thought was a really, really good instrument as a screening tool for a childhood and adolescent onset bipolar disorder. So when we had discovered this what we thought was a trait phenomena within subgroups, and so we wanted to further define this group of individuals, we performed a factor analysis that was obtained primarily from the CBQ symptom level data by parents of the 2,795 children who had met screening criteria for bipolar disorder. So we went back to the larger sample and looked at their CBQ symptom data. The factor analysis identified a unique set of CBQ dimensions. I think, and they were, and remember, we were defining these dimensions. We had never seen anything like that. There's no, and this is what is so, I guess, unique or useful about using a dimensional approach to diagnosis rather than a consensus-driven, diagnostic categories. So, and you can see on the top right, these were defined as territorial aggression, harm to self or others, self-esteem, and by that self-esteem dysregulation, and then this unusual category of or factor, which included symptoms that you just wouldn't think would segregate together, which we called psychosis, parasomnias, sweet craving, obsessions, and then the sleep disorders were a prominent feature, and we'll talk more about how prominent they actually are and what the importance of them in what we think is a way of understanding and defining the behavioral features of the phenotype. And the last but not least was anxiety, and each of these dimensions, these CBQ dimensions, are characterized by 2 to 13 specific behavioral symptoms from the CBQ. The distribution of each of these 6 CBQ factors, so we went back and we looked at how they distributed out, and it revealed highly significant differences in FOH versus non-FOH distributions, which essentially confirmed what we had arrived at in terms of symptom level, problems.
So you developed this sort of behavioral dimensions associated with FOH, and there's a fantastic PDF that I know you can find on the JBRF website that lists those 6 dimensions in more detail. And here they are. This first category, which you described as territorial aggression. Then we have that category of harm to self and others.
Excuse me, Elizabeth, yeah. I think it would be a good idea, because now we're really down to the nitty gritty. These are the actual symptoms that are the most common symptoms. Now, not everybody has these, so I think it would be worthwhile to really go through them.
Absolutely.
Because it gives you a really granular view of the condition. And if you don't mind, I will read them.
Sure.
So first of all, aggression, there are different types of aggression, at least defined in the psychological literature. There's instrumental aggression, which is basically premeditated. I want that thing over there and I'm going to get it no matter what it takes. And then there is another type of aggression, which is called territorial, and in a sense is more basic, more fundamental, more primitive, if you will. Because that has to do with someone invading your space, basically, and the response to that sense of being invaded. And so what was from the CBQ, what's segregated out in this category, or that factor that we called aggression, were irritable mood states, intolerant of delays, relentlessly pursuing one's own needs and demanding of others, willful and refusing to be subordinated by others, arguing with adults, bossy towards others, defying or refusing to comply with rules, blaming others for their mistakes, easily angered in response to limit setting, lying to avoid consequences of their actions, protracted explosive temper tantrums that famously can go on for hours, and difficulty maintaining friendships. Well, if these are the behaviors that you're exhibiting, when you want your way, it's going to be difficult to maintain friendships, and that's certainly a problem that I would say it's almost universal with these kids, and displaying aggressive behavior towards others. So again, these are all CBQ symptoms that come together in one of the factors that was established as a significantly associated with the fear of harm trait.
So next we have harm to self and others.
Yeah. So I'm going to go through them again. Has destroyed property intentionally, curses viciously, uses foul language and anger, makes moderate threats to others or self, makes clear threats of violence to others or self, has made clear threats of suicide, and interestingly is fascinated with gore, blood, or violent imagery. This is, although it wasn't part of it wasn't listed within this item. I would say is both fascinated and fearful of gore, blood, and violent imagery. It's a very paradoxical phenomena that you see in many, many, many of these kids. And one has to ask, where does this come from in the behavioral panoply? Okay, next.
Anxiety.
Okay, yeah. And this, so perhaps the most striking example of the anxiety that these children have is from the get-go. Excessive distress when separated from family, obviously, particularly from the mother, who's usually the primary caretaker. And I mean, the stories of mothers talking about this child is Velcro to my hips are numerous, and then excessive anxiety and worry are a part that you see developmentally, and eventually, often, if it's not treated, more negative cognitive ruminations that become preoccupying, and yeah, so, and we
Self-esteem, which you said self-esteem, damage to self-esteem, really.
It really is. I mean, we just named it self-esteem because we thought that these were these specific items that were factored out of the factor analysis separately were part of the regulation of self-esteem. It complains of being bored, not really able to entertain oneself, needing overstimulation, not feeling confident, and having periods of self-doubt, and easily, very, very easily feeling easily criticized and or rejected, or easily humiliated and shamed. And these are, I would say, extremely characteristic. I mean, they're not expressed directly, but often they are, particularly when you ask the child. But these are, I think, major parts of this self-esteem dysregulation that starts from a very early age.
I've heard you use the term about complaining of being bored. I've heard you use the term intolerance to boredom.
Oh yeah, I would say the activation and the provocative behaviors that these kids demonstrate have much to do with the fact that they're not able to they're not able to be with themselves. It's they're I mean, you can imagine if these children are having these kinds of feelings internally, they don't really develop an internal dialogue, which is what kind of allows you to be, have your own agency. And they do not have that, and they are always in a state of, I think, fear, and always scanning and the environment, looking for the next, for threat. So this confusing, this was the most confusing when it came together as a factor. Auditory hallucinations, visual hallucinations, night terrors and or nightmares, bedwetting, craving sweet tasting foods, I would say voraciously, hoarding or seeking to collect objects or food, and concern with dirt, germs, and contamination. This was one separate dimension that was closely associated with FOH.
And the last dimension is sleep.
Oh, yes. Yeah, and we'll come back to this in a little bit, because this again is one of the most significant aspects of the condition. Is this really a problem with sleep and arousal levels, and in many ways I've described this condition as a disorder of arousal more than a disorder of mood. So these children have difficulty getting up in the morning, terrible difficulty. They often don't get going till 11 o'clock in the morning. And this is something that's been well defined in the sleep literature called sleep inertia. And it has a lot to do with things that happen within the sleep cycle. They also have difficulty settling at night, getting to sleep at night, and difficulty when they do get to sleep, they sleep fitfully and waken often in the middle of the night. And that's, again, very characteristic something that we now have the capacity to monitor very closely on a nightly basis, thanks to this wonderful tool that's been produced by the Withings company, which I'm sure we can get to at some point. So
these were 6 dimensions that varied significantly from one another. How did you go about determining that this behavioral trait that you had dubbed fear of harm was a heritable one?
Yeah, well, that was really the next step. And we were concordance and a concordance analysis is which is done to try to determine whether there's concordance is defined as the probability that a pair of individuals will both have a certain characteristic, a phenotypic trait, if you will, given that one of the pair has the characteristic. So a pair is considered concordant if they both possess an attribute of interest, such as the FOH trait, and they're discordant if they differ. The concordance rate is used to estimate the influence of nature, genetics, and nurture, the environment, on a particular trait, disorder, or disease. This can be measured with concordance rates reflecting the odds of one person having the trait if the other does as well. So, with a very large sample size that was available to us, we had clinical profiles from a sufficient number of affected sibling pairs to enable us to perform a concordance study of the 10 CBQ behavioral dimensions in 260 proband sibling pairs and 260 proband matched comparison pairs, not siblings, to determine whether this phenomena was a heritable trait. And these factors were then analyzed for concordance. So if we look at the concordance rates, we see, and the way it's measured is the measure is called rho, which is the concordance coefficient, and rho measures the degree of association between a particular trait or set of traits between two sibling pairs. For example, if the fear of harm factor, the proband sibling rho estimate, 0.287, was substantially larger than the corresponding proband comparison rho estimate of 0.018. And this difference was highly statistically significant, the p-value of 0.001. And similarly, for the aggression factor, the two estimates for rho were 0.246 versus 0.014. And this difference in rho was also highly significant at a p-value of 0.006. So these were really demonstrate in all of these dimensions that we're looking at relatively high concordances, within the sibling pair groups, and this is an indicator of a heritable behavioral trait.
So were you able to determine how widespread this phenotype is, how many people it impacts?
Well, Elizabeth, to really determine that, you need to do a epidemiological study, a general population study, we had a general population study, but it was very, very I would say skewed. We looked for a certain group of individuals, but we had a large number of those individuals, and so we can extrapolate. If we estimated individuals with the fear of harm trait within the bipolar population, And if we look at the rates, the prevalence rates, 1/3 of the general population diagnosed with bipolar disorder. So that would tell us that there's 5.7 million individuals, and about 1/3 we would suspect which is nearly 2 million individuals, would have the FOH trait. In the general population of children and teenagers with BPD, there's 1 million, and looking 1/3 of those would mean that there's more than 325,000 children and teens with the FOH trait who have bipolar disorder.
And of course, these statistics are based just on the United States. So presumably there are many, many more people worldwide who are living with this. So how did you develop a way to identify the disorder clinically?
Well, besides looking at the core index on the CBQ, which I think is really the in terms of our behavioral studies, that's the main that would lead you to think that this child has this condition, but again, this was all being conducted essentially. I guess you could say, without having seen the kids. Someone had seen them to diagnose them as having bipolar disorder, within the community. But when we started evaluating children who met the full criteria for FOH and who had diurnal mood cycling, we were struck really rather immediately by the reports and the direct observations of significant thermoregulatory disturbances in almost all of the cases that we saw. Very prominent intolerance to heat, overheating in neutral ambient temperatures, periods of what sounded like torpor during the day, overheating before sleep, and waking up with bed sheets that were soaked and malodorous. So, and additionally, for those that were in the northern climates, we would hear stories that really stretched your imagination about severe cold tolerance. To give you one of many examples, one mother told me about her 12-year-old daughter who would periodically rush out the front door to dive butt naked into a snowbank and not feel the sting of cold. On many occasions, I witnessed in my office the rapid changes in facial flushing and characteristically the reddened pinna of the ears, which is the tips of the ears. And as I began to explore the thermoregulation literature, I was to later learn that for some mammals, the pinna is considered the radiator for the brain. So the periods of obvious flushing in my patients were also during responses to stressful events. This was something I had never seen before, and I later learned that it was a well-known physiological phenomena that had been described many years before, which is called emotional hyperthermia. So the consistency of these reports over the last 12 years in hundreds of cases make it crystal clear that there's some deficit in thermoregulation and thermosensation, and that this is very likely a highly correlated marker for the condition.
So for our audience, for some folks who may be looking for real life examples of what this looked like, we collected reports from parents that include saying when our daughter was little, she would always seem to get very hot right before bed or an hour or two prior to bedtime. She would go to sleep with multiple ice packs on her just to cool off enough to fall asleep. Another parent said our daughter always wanted to strip down when she got home, even in winter. She fought wearing clothes, and she always had red bright red cheeks. Another parent said it took us a long time to see the connection, but if our son is hot, if he goes outside in the heat for even an hour or two, he cannot regulate his emotions for the rest of the day. And that night, his nightmares are much worse. Another parent said probably the worst time of day was late afternoon to early evening around sunset. That's when my son got most overexcited, overstimulated, and angry. That changed when he started getting the right treatment that actually regulated temperature. Dr. Papolos, can you explain more about this obvious connection between temperature dysregulation and sleep disruptions and how the symptoms can be identified?
Sure, I'll try. Um, so, obviously, one of the things we when we had realized this, just really from clinical observation, we wanted to find out whether there was some kind of biomarker that we could use, and so we did a study in a sleep lab. This was at Cornell many years ago now. What we what we understand about that there's a circadian pattern of core body temperature, which results from the balance between heat production and heat loss. And that sleep under entrained conditions, entrained light-dark conditions, is typically initiated during the declining portion of the core body temperature rhythm, when its rate of change and body heat loss is maximal, usually before lights out. And this happens through the selective vasodilation of distal skin regions, which promotes sleepiness and the rapid onset of sleep. So what does this mean, actually? Well, so when we go to sleep, we lie down, all of us. Basically, our body starts to cool down, and during the night, most of the night, our bodies are cooling, because what generates heat during the day is muscle activity and also brain activity. These are the things that nature had to develop a very sophisticated system for regulating temperature in the bloodstream. It's really between 2.5 and 3 degrees. If you go one way or the other, your proteins denature. So you don't survive as a mammal unless you can regulate temperature. And there are obvious emergency signals on either side of that coin. And so temperature is in essence, a signaling system. And we can see that one of these, what happens when you go to sleep is your blood vessels open up, and that's how you dissipate heat, and that's how you're losing heat. It's very, it's like steam coming out of your ears. And to go to sleep, there's a point in the circadian temperature rhythm where your skin temperature equals your core body temperature. When that occurs, and you can see that in the first part of this slide, at the beginning and entry into sleep, it's like a window opens up, and you go into sleep, all of us. And then the temperature varies throughout the night and varies through the REM, non-REM 90-minute or ultradian cycle. So, and temperature is also a significant signal for that as well. And you can see that in the normal temperature difference between the skin and the core, and then in the child that does not have FOH, you see the unity point going into sleep and again coming out of sleep. And if those 2 points, basically, if that doesn't occur, it's very hard to go into sleep. And it's also very hard in the morning to get out of sleep. And this to us was a really good way of explaining why these children have problems with sleep onset, insomnia, and why they have the sleep inertia. That the temperature, this important measure of thermoregulation, the difference between skin and core temperature, is off, largely because they are running hot much of the time. um, and this delays what's called the distal to proximal gradient in some children for nearly an hour. In some children, it never occurs at all, and they have very, very fitful sleep. So again, this explains a whole number of potentially explains a whole number of the symptoms that we see with FOH.
So now you have some graphs here on REM and non-REM sleep.
Yeah. So I'd mentioned before, and we think about this as, both temperature and sleep are coupled. The circadian temperature rhythm, the 24-hour diurnal rhythm, is coupled to the temperature rhythm, and what's called an ultradian, meaning less than 24 hours, which is it's actually a 90-minute oscillator, about 90 minutes, that varies through the course of the sleep cycle, and essentially determines when you go into REM and when you go out of REM, and into non-REM sleep. And this transition really needs to be stable for you to have a sufficient amount of REM sleep, which is very, very important, and likely a survival function that was developed and nurtured over evolution because of the functions of REM, the many functions of REM, and also deep sleep, which, for both of those things are really impoverished in these children. And what this slide points to is the interruption here, and maybe we can look at the next slide that gives us circles it a bit better. Can we move to the next slide?
This is the next slide with the orange identification on the sleep disruption.
I'm not seeing it. Okay, there we go. Yeah. So you can see during each of these nights, and this is one child, this is two separate nights, there's a REM period that is interrupted by an arousal state. In the first, this interruption happens before, and in the second, after this small REM period. So, and we know from the literature on parasomnias, arousal disorders of sleep, which are a whole host of symptoms that these kids have, including teeth grinding, sleep talking, sleepwalking, nightmares, night terrors. All of those things are part of arousals that are caused by an unstable transition between REM and non-REM sleep.
So this data must have generated a whole new set of questions.
Absolutely. It really, I would say, shaped the research that we've undertaken over the last 2 decades, and to look really for how does this biological deficit, manifest itself in behavioral symptoms, and to what extent is a disturbance in heat dissipation, that is the ability to throw heat off and lower your core body temperature, or heat generation, as well as the observed problems with thermosensation. How are these associated with the sleep disturbances that are the cardinal symptoms of the phenotype? And that's been a significant question that we've grappled with. Now, secondly, we asked, did these recurrent REM arousals in mid-phase lead to fear sensitization through auto-traumatization? Did the, massive recurrent periods of recurrent nightmares going weeks, months sometimes, that manifest very early in life, were these in some way responsible for what we see and what we identify as a trait marker, that the intense fearfulness and the reactive aggression to perceived threat and avoidance behaviors that are really, hallmarks of the phenotype?
So you've enumerated beautifully that sleep and temperature are linked. But why is it that temperature is so important to sleep?
Well, I think I tried to explain that earlier. But I'll give it a go. I mean, there's an increasing awareness that there is a more specific homeostatic challenge to maintain brain temperature. As central nervous system function really is dramatically affected by slight shifts in temperature, and this is something that is not particularly well known or discussed or described. Certainly not in psychiatry, and probably not in most of medicine, except for hyperthermia and hypothermia, and that's about the only place that it's paid attention to. But I mean, when you think about it, like it's kind of like a computer central processing unit. The brain has a tremendous potential to run hot and overheat, and at no time more than during rapid eye movement sleep, when heat dissipation mechanisms actually throttle down. So the body basically turns off your capacity to throw heat off during REM. It's the only time that happens during the 24-hour period. And the brain activity rises dramatically during REM. There is so much going on during REM of importance in terms of emotional memory, in terms of sorting through fear memories, and other phenomena that I won't go into, but and also at that time, although the muscles are paralyzed, the eye muscles, the oculomotor muscles, are not. They are firing very, very rapidly. That's why it's called rapid eye movement sleep, and that generates some heat as well. So so it's a very vulnerable time for many reasons for the organism, and we can see, for example, in this slide, that entry in and out of REM, here seen as in desynchronized EEG in the slide, and non-REM in the synchronized EEG, sleep are directly correlated with EEG changes, fluctuations in core temperature, and also theta wave activity and theta wave frequency, actually, which is very important. Witten and colleagues found that there was a direct cross-correlational function for the core temperature and neocortical 1 hertz power. So that's within the theta range, which demonstrated a coupling of the two signals. Now, given that theta has been directly associated with emotional memory consolidation, these findings certainly bear on fear memory and suggest that disruptions in REM sleep, which have long been associated, and there are a number of studies that have shown that this is a common phenomena that occurs in PTSD. This is more towards being able to conceptualize and thinking about how temperature may very well, temperature dysregulation, the disruption of REM, and then leading to problems with emotional memory. All of those things are, it seems to me, very likely when you look at the whole picture.
So it looks like these are some of the sleep-wake cycle discontinuities that you were referencing.
Yes. And again, this is both in the circadian, the 24-hour rhythm, and the ultradian, the almost every 90-minute domains of sleep. And as we began to further investigate the effects of the thermoregulatory disturbance, it became clear that temperature dysregulation was responsible for all of the disturbances that we saw in sleep, the initial insomnia, the middle insomnia, early morning awakening, and the arousal disorders that we talked about previously, as well as something that we didn't discuss, but is quite commonly seen, particularly during the circannual transitions in light, dark, and temperature cycles, where there's a tendency towards periodic lengthening or shortening of sleep duration. And these sleep-wake cycle discontinuities seem very, very much dependent or related to the temperature dysregulation that we see most commonly with fear of harm.
And parents describe this. One said, my son had terrible nightmares from a very early age. He would wake up screaming every night, multiple times a night. The nightmares were so traumatizing to him that the point that he would really resist going to bed. During the day, he'd be haunted by memories and imagery from the nightmares. And another parent said, my daughter's sleep was always an issue. She would be up until literally between 2 and 3 a.m. every night, even as a toddler. She'd come into my room, wake me up. I'd lie in her bed with her for the rest of the night. Dr. Papolos, can you give us an understanding of the science behind what these kids are experiencing?
Yeah, I think as we discussed that, I mean, basically what we are we understand that this complicated phenomena that when we began to look at the wider neuroscience literature, and we found that it had been well established that temperature had a profound effect on sleep. Not only when we go to sleep, but when we arise in the morning, and with the transitions from REM to non-REM. These disruptions to all of these can produce many of the symptoms that we've discussed so far.
And your hypothesis, how did you get from here to the fuller picture that you have now?
Yeah, well, we posited that fear of harm is a heritable tendency to generate excessive heat and to inadequately dissipate the heat, resulting in a propensity and disturbances in transitions between REM sleep and non-REM sleep, and multiple arousals during sleep in childhood and beyond. And these sleep disturbances include shortened REM latency and all of the parasomnias we've talked about earlier that occur commonly with these children, and particularly, and I point this out again, the arousal disorders of sleep, and particularly the vivid, horrific nightmares and night terrors that these kids experience. They typically involve the imagery of gore and annihilation and abandonment, and these are occurring during the perturbations of transitions from slow to fast wave sleep, which are governed by temperature changes in the brain. So what we proposed is that for these individuals, during the switch from non-REM to REM, when the heat dissipation mechanisms throttle down and saccadic eye movements are coupled to increases in brain activity that result in heat generation. And when the temperature, which is already high, gets too high, the brain serves up a survival alarm that's triggered by the elevation of brain temperature. And the content of the imagery produced, and the vividness and emotional salience of the experience of these life-threatening events during the night terrors and nightmares sets the stage for fear sensitization that can be carried over into the day. So, and we've elected to call this psychological phenomena auto-traumatization.
So we've come to the end of our time for tonight. So we're going to just quickly show a summary of the characteristics of fear of harm that you, Dr. Papolos, and your colleagues identified, including temperature dysregulation, circadian rhythm, and ultradian sleep discontinuities, difficulty transitioning from low energy and high energy states, episodic abrupt shifts in mood, deficit in reward motivation and self-esteem regulation, low threshold for startle, misperception of neutral tones of voice and facial expressions as threatening, poor regulation of aggressive, acquisitive, and appetite drives, and oppositional and defiant behaviors in response to criticism, perceived threat, or loss. Now, next time, in 3 weeks, when we meet again on June 12th with Dr. Papolos, he's going to take us through the next piece of this story, which was the identification of treatments that were successful in managing the symptoms of this newly identified phenotype, FOH. So with that, I'm going to stop the share. I know a lot of questions came in through the Q&A. We have a third session lined up for June 26th that will be 100% a Q&A with Dr. Papolos, so we can get a lot of these questions addressed then. We'll also be sending out these questions to everyone who was here with us tonight so that you know what questions were asked and what will be answered at our future events. But I want to check in with Jim from JBRF to see if there are any questions that he wants to bring up now, or to see if Dr. Papolos has anything that you'd like to add. You know, I have my own question, which is this evidence that you've presented, and I've heard you present before, is so compelling. I'm wondering why it is so hard for people to grasp this connection between temperature dysregulation and the profound impacts that it has on behavior and emotional dysregulation that these kids and adults who have FOH experience.
Well, that's one of the $64,000 questions, Elizabeth. It's you know, look, this problem, I think, is multi-pronged. One, we know from experience, unfortunate experience, that within child psychiatry today, there continues to be this myth that childhood bipolar disorder does not exist. And this is what the force that many parents encounter when they go looking for somebody that will treat it. So I think largely we can so if it doesn't exist and you've never treated it before, it's going to continue to not exist. And so when something comes on the scene that says, oh, look, we've used this dimensional approach that's used in genetic studies that's been shown to have that's been shown to prove effective in identifying different phenotypes, and we're talking about bipolar disorder in children. And this is a separate phenomena that we're claiming is heritable, and we've actually found treatments that there's a thermoregulatory basis. You're not preaching to the choir. It's a very tough sell. And I think it has remained that way for many years, to my chagrin, and also tragically for many parents and children.
Mm-hmm. It's like an onion, each layer with its own set of obstacles.
Thank you, Demitri. So I will share some of what we've heard in the chat, which has been incredibly rich. So I thank people for posing great questions and thoughts as we've moved through. Dr. Papolos, you actually anticipated one of the questions already, which I don't think you need to answer because you have, which is the question of why is there so much resistance and reluctance to recognizing bipolar disorder in children? So I think you've covered that already, but it really is a key question to the work we do, and hopefully one that we'll spend some time on in our final session, which again is an open-ended question and answer session. There were a handful of questions related to treatment of fear of harm, and we're actually going to bank those questions and hold them until the next session where we'll go in deep on that. But we will look at those prior to the presentation to make sure we are responding to those individual questions. There also were several very rich questions related to individual situations, situations for our patients, for our children, for our clients. We probably don't have the ability to go deep on those today, but again, we're going to capture those and find ways that we can get information out to you. I am going to pose a few questions that came in around FOH characteristics, which I thought were great. The first of those is a three-part that says, does the intensity of the systems of FOH decrease over time? With that, does the frequency of episodes decrease as the child becomes a young adult? And third part, would FOH look different in a 20-year-old and up?
Those are all excellent questions. And I think there's something we can take up. I mean, I'll try to answer as best I can now, but I think it deserves perhaps a lot more time than we have because it gets to the heart of why it's so important to diagnose these children early on. And we have a way. The CBQ was normed, from age 6 on, and we can easily diagnose these children by age 6. I mean, they're already manifesting a multitude of symptoms, and so the first responders are usually pediatricians, and we can talk, I'm sure. Elizabeth and you and many people can talk about what happens when you take your child with severe nightmares to and night terrors to pediatricians, unfortunately. But we don't have really a system that's set up within the larger community to identify these children early on, and they are identifiable. I mean, I've identified children as early as 4.5 years old. In fact, it was one of the first children that we treated with ketamine, and I'm happy to say she just graduated this year from college, and has got a job and is going off to work, basically. So I'll just tell you, I'll share my clinical experience with at least one part of this, and that is that it's a different condition if you diagnose it and treat it early on than if you wait till age 5 or 8 or 20, because you have to remember that these behaviors that emerge, however they emerge, whether it's through the way that we hypothesize they emerge, the aggressive and defensive aggressive behaviors, the perception, the constant sense that of perceiving threat where there isn't threat, and responding to it impulsively, this becomes a repertoire of behaviors that essentially becomes conditioned over time. And so the longer this goes on, the more nightmares that occur in our minds, the recurrent trauma occurs. And from a psychological perspective, even if the nightmares subside after age, let's say 10, or they get less and less, it's like anything that gets reinforced. Intermittent reinforcement is more potent than regular reinforcement. I mean, this is a basic psychological concept. So, it's really this is really a difficult condition for everyone. And if we could just identify them early and treat them, the treatment would be a lot simpler. And so it would be, I think, we'd be in a much better world.
Dr. Papolos, if I may jump in here, I also want to point out that we didn't discuss it today, but there's another measurement that you developed that works in conjunction with the CBQ in helping identify this disorder in young children, and that's the Janie and Jeffrey Illustrated Interview for Children, which to my knowledge is the only assessment out there to test for bipolar disorder that is actually for the child themselves to fill out. It's in cartoon style drawings with a Likert scale so that they're able to identify for themselves which symptoms they're experiencing, how intense they are. And it facilitates that process of understanding, not just from observing signs, which we often label as behaviors, but also to get inside the child's experience themselves of what these symptoms really are like for them.
Yeah, thank you for bringing that up, Elizabeth. That is, I think, really important. And often, I mean, when the parent does the CBQ, because it's a parent reporting device instrument, and the child does the Genie or the Jeffrey, the child's reporting things that parents may not have known or seen, because it's much easier to respond to the cartoon Genie or Jeffrey as another child that is just like them.
Right.
Yeah.
Demitri, one of the questions we had around how FOH presents is, and this is related to the aggression that we talked about, is can you see children aggressively shutting down and not just outwardly aggressive? So turning inward as opposed to being explosive.
That's a good question. I can't say that I can't say that that's something that I see very, very much. I think what happens is you can have significant avoidance behaviors that develop, and where aggression may not be so pronounced. The avoidance behaviors become very, very pronounced.
Another specific question we had related to the characteristics is, do you find that children also experience difficulty with loud noises? Is that a piece of this package, or is it outside of it?
Yeah, typically it's not universal, but most, if not a majority, have very heightened startle responses.
Yeah, that was on one of the final summary slides. Low threshold for startle, deficit in capacity to habituate to sensory and environmental stimuli.
Demitri, there's a great question here related back to the topic of nightmares and night terrors, which is, can't psychiatric medications sometimes cause and induce nightmares, and how does that fit together with this syndrome?
Yeah, they can. I think we've not been looking for those, but we know that unfortunately the several groups of medications that are typically used in to treat these children initially, who are usually diagnosed with some kind of anxiety disorder first, then obsessive compulsive disorder, then the oppositional defiant disorder. So they get on a whole panoply of medications. I don't think we've been able to single out which ones may be causing nightmares more than others, but we know that really from much of the historical experience that antidepressants are really verboten, and they and stimulants without treating the bipolar disorder first just worsen the course of illness significantly. I don't know whether they would also cause nightmares. I mean, one, thought is that, both of those neurotransmitters are incredibly important in the regulation of temperature. So anything that's altering temperature regulation in these children, has a potential, if it goes the wrong way, to really make things worse.
So Dr. Papolos, and I know we have to finish up before too long, we have a couple questions related to really where you started with this presentation, which is how FOH can appear like so many other challenges that are out there, and that the sort of components of what we recognize in FOH are in the DSM, but not as FOH. They appear in terms of other challenges. So one question was, I noticed so many symptoms that are consistent with autism and the PDA form of ASD. Could you elaborate on differential diagnosis, please?
Yeah, well, that's a tough question. I think there is a subgroup of kids that have FOH, a number of whom I treat, who also have there are different ranges on the spectrum, but I think there are kids that get diagnosed with autistic spectrum disorders because of their social anxiety or some basic features that may or may not have that particular diagnosis. I think the larger problem is this. It's not just one diagnosis, is that this condition overlaps, the symptoms overlap with so many conditions that, as we all know, have been determined by consensus. They're not evidence-based. There's no condition that's in the DSM that is evidence-based. It's basically determined by groups of experts that have come about and decided this is the way it looks. And so because of that, you have another condition that overlaps many of them. So, and typically what we see historically is we'll see that these kids get diagnosed with 4 or 5 different conditions before they ever get considered to be first bipolar. They're rarely described as having fear of harm, but even the bipolar disorder doesn't come till adolescence, where there's an agreed upon orthodoxy that believes that's when it can occur, but not earlier.
Excellent, thank you. And Dr. Papolos, one other question sort of related to what we just spoke of was the question of comorbidity with HSP. Can you speak with that at all?
I'm sorry, HSP?
Yeah, I'm not sure what, that's the acronym that the questioner has used here.
I don't know, not familiar to me.
Okay, then let's move on. I think a question
I can, that's a term that's being used now. It's not a diagnostic term, it's a highly sensitive person.
Well, these kids, I would say, are very highly sensitive. Yes. So they would qualify as having HSP, all of them. They do have this form, as I mentioned, of like territorial aggression, and they have, fairly high startle responses. They're always misperceiving things as threatening when they're not. So they're very, very sensitive in all of those ways.
So I may have just one other question that may be on the minds of participants here, and thank you to everyone for being a part of this, over 100 people being a part of this conversation, which is the question of, given that so few people and so few clinicians at this point in time are really aware of this phenotype, how do you go about funding this research? How do you go about funding the treatment developed? How do you go about funding the work that the Children's Mental Health Resource Center does in supporting kids through this? And it's a bit of a softball question because it's a pitch for your support over time, but it really does speak to the challenge of doing work that many people don't even know needs to happen. Elizabeth or Dr. Papolos, any comments on that?
I think we really work in parallel with one another. The research that comes out of JBRF is instrumental in our educational work and in our advocacy work and in being able to navigate the mental health care system, which is unnecessarily complicated for families. And so, part of what we do is to say we're mental health professionals, we're families, we've walked this path with other families, let's help you get to the place of stability. And so we're really two prongs of the same mission, which is to ensure that children get the accurate diagnosis and effective treatment that they deserve so they can thrive. JBRF does the research, and we do the hand holding with families to make sure that they get what they need. And our support comes from everywhere, from foundations and institutional funders to grateful families who've appreciated the support we've provided and make a gift. And it is Children's Mental Health Awareness Month. So now would be a great time to give. You can do so through the CMHRC website to us, and you can give to JBRF through your website.
Oh. Yeah, I would have a simple answer to the question, and that is with enormous difficulty. And it does come with, it's really largely family and individual donations. And fortunately, I mean, it's sometimes we're able to get a foundation that's particularly focused on bipolar disorder, which is rare, to give us funding, as we did recently. The Milken Foundation funded a study on looking at vagal nerve stimulation as a treatment or as an adjunctive treatment for this condition.
So I'm going to go to one more question and comment that came from the Q&A, and I appreciate everything that's here. And again, we have captured it all, and we'll look at this as we put together our future sessions. But the last question that came from Deborah is, can I reach out to you? And we know that this work can be isolating, very much so for parents, and we know it can be tricky for clinicians when you're surrounded by others who aren't yet familiar with this work. So the answer is yes, you can absolutely reach out to us. Again, we've captured what you have in the Q&A and may reach out to you about some of those. Also, both JBRF and CMHRC are responsive organizations that you can reach out to anytime through our websites, and we would be glad to offer any support we can.
Absolutely. Well, thank you again to everyone for being with us. We are going to be here again on the evening of June 12th to talk about part 2, which is the identification of treatments to address the symptoms and the causes of fear of harm. So if you've registered for tonight, you're registered for that. We look forward to seeing you then, and have a wonderful rest of your evening, everyone. Thanks so much. Good night.
Right.